Welcome to the Hospital Medicine Unplugged podcast.
Today we're doing a critical deep dive, focusing on acute pancreatitis, one of those GI emergencies that honestly can be incredibly unpredictable in the hospital setting.
Absolutely. It's a condition where, those first decisions, those first 24, maybe 48 hours can make all the difference. We're talking the difference between a relatively short stay and weeks in the ICU.
That's the crux of it, that variability. So our goal today isn't just to review guidelines line by line. We want to synthesize the latest thinking, drawing from the ACG, the IAP, recent reviews, really get into the nitty-gritty of managing these hospitalized patients.
Right. We need to talk about practical things. How do we effectively risk stratify early? What does truly goal-directed supportive care look like? And critically, getting the timing right for interventions, surgical, endoscopic, depending on how severe it is and, well, what caused it in the first place.
And, if you're managing these patients on the floor or in the ICU, you know the stats. Overall, mortality might seem low, maybe under 2%, but that hides the real risk.
Yeah, that 20% or so who progress.
So exactly. Around 20% develop moderate or severe disease. And for those patients, mortality jumps dramatically. We're talking 20, sometimes 30%.
So our focus is really on nailing that early management, catching that deterioration before, say, transient organ failure becomes persistent, providing those details needed to intervene effectively.
Precisely.
Okay, let's lay the groundwork first, the pathophysiology. Because really, understanding why the pancreas is essentially self-destructing helps justify why we're so aggressive with supportive care right off the bat.
It's not just simple inflammation, is it? It's autodigestion.
That's the key. It's this acute inflammatory process. But the defining feature is that digestive enzymes, particularly trypsinogen, get activated prematurely inside the pancreas itself.
Right. Trypsinogen converts to active trypsin, and boom.
Right.
Trypsin then activates a whole cascade of other enzymes, phospholipase A2, elastase.
And they just start breaking down the gland from the inside out.
Exactly. That's the autodigestion part.
So what makes it systemic? Why does it affect the whole body?
Well, that initial injury to the pancreatic acinar cells triggers this massive release of inflammatory mediators, cytokines, chemokines, the whole inflammatory soup gets dumped into the circulation.
So that's what drives the SIRRUS, the systemic inflammatory response syndrome.
Precisely. And that systemic inflammation leads to leaky blood vessels, endothelial damage, fluid third spacing everywhere, and if it gets bad enough, multi-organ failure. Understanding that the initial pancreatic insult drives this systemic response is why things like aggressive fluid resuscitation are so fundamental. We're trying to maintain perfusion and prevent that downward spiral.
Okay, so we suspect it. How do we actually confirm the diagnosis at the bedside? We usually rely on the revised Atlanta classification criteria, right? Need 2 out of 3.
Correct. 2 out of 3. First, that characteristic abdominal pain, usually pretty severe, constant epigastric pain, often boring right through to the back.
Can't miss that pain usually.
Not usually. Second, labs. Serum amylase, or preferably lipase, greater than 3 times the upper limit of normal.
And lipase is generally better. We'll come back to that.
Yes. And third, characteristic findings on imaging CT or MRI. But, and this is a big but, imaging isn't usually needed right away if the first 2 criteria are met.
Right, save the imaging for when the diagnosis is murky, or if they're not getting better.
Exactly.
And just thinking about how common this is, it's not some rare zebra. For us in hospital medicine, this is bread and butter, unfortunately.
Oh, absolutely.
Yeah.
It's arguably the most common GI reason for hospitalization in the U.S.
Yeah.
We're talking something like 300,000 admissions a year. And the numbers seem to be going up, possibly linked to rising obesity, more gallstones.
But again, it comes back to that severity split. Most do okay.
Most do. Overall mortality is low. But if you land in that severe category, persistent organ failure, your risk skyrockets. 1 in 3 mortality isn't an exaggeration in those cases. So recognizing who's heading down that path early on is paramount.
Before we get into diagnosis details, maybe a quick word on communication. Precision matters, right? Especially when we're talking about complex cases, handing off patients, documenting.
Absolutely critical. For this audience, fellow physicians, we don't need to review basic terms, but let's emphasize using the right terms in context. For example, when we discuss complications seen on CT.
Yeah, distinguishing between an acute necrotic collection versus walled-off necrosis, it sounds similar, but the timing for intervention is completely different based on that distinction.
Totally different. And same goes for etiology. It's not enough to just say gallstone pancreatitis. Is there cholangitis 2? Is there choledocholithiasis? Because if either of those is present,
that triggers an urgent ERCP, usually within 24 hours.
Right. The whole management pathway hinges on that specific, accurate description.
And thinking ahead to antibiotics, which we'll definitely cover, being precise about why we choose certain agents, we might pick something like, say, impinim-celistatin.
Yeah, because of its ability to penetrate necrotic tissue. That's a very specific pharmacokinetic need. Good antibiotic stewardship here relies on that kind of precision in selection for these high-risk patients.
Okay, good point. So let's dive into those first 24 hours. We've got the patient, we suspect pancreatitis. Priority shifts now from just diagnosing to really figuring out how sick they are, right? Severity stratification.
Exactly,
Yeah.
because that determines where they need to be floor, step down ICU, and how aggressively we monitor and treat.
Yep.
Starting with labs, you mentioned lipase is preferred over amylase. Why is that?
Well, lipase just performs better, diagnostically speaking. Higher sensitivity, higher specificity for the pancreas.
And amylase has limitations.
It does. Its half-life is shorter, so it can return to normal pretty quickly, maybe within 48, 72 hours. So if someone presents late, you might actually miss the diagnosis if you only rely on amylase. And importantly, amylase can be falsely normal or only minimally elevated in a couple of key groups. Patients with chronic alcohol use whose pancreas might be a bit burned out.
Right.
And patients with hypertriglyceridemia-induced pancreatitis, lipase is generally much more reliable in those situations. So yeah, lipase should be your go-to marker.
That's a really practical point, especially in the ED, where the history isn't always crystal clear.
Okay, imaging. We both know CT scans get ordered way too often right at the start. When do we actually need that CT or MRI early on?
We really need to push back against that knee-jerk CT order. Look, if you have the classic pain and the lipase is clearly elevated more than 3 times normal you've made the diagnosis, you don't need imaging to confirm it.
They'll reserve it for.
Reserve it for when the diagnosis is genuinely uncertain. Maybe the pain is atypical or the labs are equivocal. Or the really big indication, if the patient isn't getting better after, say, 48 to 72 hours of good supportive care.
That's when you start worrying about complications developing, necrosis, collections.
Exactly. That's when imaging becomes crucial to see what's going on structurally.
And if we do image for complications, contrast-enhanced CT is still the workhorse.
It is. CECT gives you the best look at the extent of any necrosis, maps out fluid collections, helps tell solid tissue from fluid,
Yeah.
but let's not forget ultrasound early on.
Right, for the gallbladder. Yeah, simple bedside ultrasound is invaluable right at the beginning to look for gallstones, sludge, or a dilated common bile duct. That points you immediately towards a biliary etiology and might change management urgently.
Okay, diagnosis confirmed.
Mm-hmm.
Now, severity. The revised Atlanta classification really is central here, isn't it? It guides everything. Let's break down those categories. Mild first.
Mild acute pancreatitis, or AP, that's the straightforward one. By definition, no organ failure, no local complications like necrosis or collections, no systemic issues beyond the initial inflammation. These folks usually turn around pretty quickly with fluids and pain meds.
Resolve within a week, typically managed on a regular floor.
Correct. Then you get to the middle ground, moderately severe AP. This category is important because these patients need closer watching, but maybe aren't quite ICU bound yet.
So what defines moderately severe?
It's defined by having one of 3 things, or maybe a mix. First, transient organ failure, meaning it develops but resolves within 48 hours. That's key. Second, having local complications, maybe a peripancreatic fluid collection, maybe some necrosis is visible on imaging. Or third, an exacerbation of their underlying comorbidities triggered by the pancreatitis.
The key word being transient organ failure. If it flips back quickly, the prognosis is still much better than severe.
Much better. And that brings us to the most critical category, severe AP. If a patient meets criteria for severe AP, that's usually an automatic ticket to a higher level of care, often the ICU.
And the defining feature here is non-negotiable.
Non-negotiable. Severe AP is defined by persistent organ failure, meaning organ failure that lasts longer than 48 hours.
Okay.
It could be respiratory failure, cardiovascular collapse or shock, or acute kidney injury, or a combination. We typically use the modified Marshall scoring system to quantify it. But the duration, more than 48 hours of organ failure, that's the absolute determinant of severe AP and the strongest predictor of mortality, more so than the amount of necrosis sometimes.
Right, so if the organ failure sticks around past that 48-hour mark, it's severe AP, period. regardless of what the initial CT might have looked like.
Exactly.
Since that Marshall score is so central, we should probably be specific about the cutoffs.
Yeah.
What are we looking for at the bedside to say, yes, this is organ failure?
We need objective metrics. For cardiovascular failure, it's shock, usually defined as systolic blood pressure under 90 mmHg, often needing vasopressors.
Okay.
For pulmonary insufficiency, it's hypoxia, a PaO2-FiO2 ratio less than 300, or just a PaO2 under 60 mmHg on room air or supplemental O2.
Got it. And kidneys.
Renal failure is defined as a serum creatinine greater than 2 mmHg, but crucially, this is after giving them some initial fluid resuscitation. You want to make sure it's not just pre-renal azotemia from dehydration.
Good clarification. So those are the targets we're monitoring closely in those first couple of days. Now, besides Atlanta, we have other scoring systems, BISAP, APACHE II, Ranson's. They can be a bit cumbersome. What's their proper role?
I'd say their role is supportive, maybe auxiliary. Tools like BISAP are nice because they're simple. 5 bedside variables. BUN 25, impaired mental status, SIRS criteria met, age 60, and pleural effusion.
Easy to calculate quickly.
Yeah, helps you quickly flag patients who might be higher risk, maybe need that step-down bed or closer watching, helps with triage and resource allocation. But, and this is crucial, they are guides. They absolutely cannot replace clinical judgment.
Right. Treat the patient, not the score.
Exactly. If the BISAP score is low but the patient looks terrible and is circling the drain, you act on your clinical assessment. The scores help anticipate, maybe identify that 10-20% likely to get into trouble, but they're not definitive.
Okay, makes sense. So we stratified severity. Now we move to the cornerstone.
Right.
Supportive care. And the absolute #1 intervention here is fluids.
Fluids, 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 early and generally aggressive.
The timing is critical. Needs to start ideally within the first 12 to 24 hours. The whole point is to counteract that massive fluid loss from third spacing into the retroperitoneum and just the general leakiness caused by systemic inflammation.
Getting that volume in early can potentially prevent or limit pancreatic necrosis by improving microvascular perfusion. It really can change the course of the illness.
And the choice of fluid matters too. The guidelines pretty strongly recommend lactated ringers over normal saline. Why is that? It's more than just avoiding hyperchloremic acidosis, isn't it?
It seems to be. Yes, LR is balanced, less chloride avoids the acidosis you can get with massive saline volumes. But there's growing evidence LR might actually be, well, anti-inflammatory.
How so?
Studies have shown patients getting LR tend to have lower levels of inflammatory markers, like C-reactive protein, compared to those getting saline. The lactate gets metabolized to bicarb, sure, but there might be some direct effect on modulating that SIRARS response. So it's potentially a therapeutic choice, not just about electrolytes.
Interesting. So LR preferred. How much initially? What kind of rates are we talking?
Initial rates are usually pretty generous, especially for younger patients without heart or kidney problems. Maybe 5 to 10 milliliter per kilogram per hour for the first few hours.
But it's not just set it and forget it.
Absolutely not. It has to be a goal-directed approach. You start with a reasonable rate, but then you're reassessing frequently, maybe every couple of hours initially, and adjusting based on clinical targets.
Okay, let's list those targets. What are we shooting for to know we're resuscitating effectively?
We want to see clinical signs of good perfusion, so aiming for a heart rate under 120, getting the mean arterial pressure, the MAP, into that 65 to 85 mmHg range.
Urine output.
Crucial, urine output greater than 0.5 to 1 millimole per kilogram per hour. That tells you the kidneys are getting perfused. And watching the hematocrit is helpful too.
How so?
We want the hematocrit to stabilize, ideally somewhere between 35% and 44%. If it keeps climbing despite fluids, that suggests ongoing hemo concentration. They're still effectively dry, still third spacing.
Right. But there's a flip side. You can overdo it, especially in certain patients.
Exactly. This is where clinical judgment is paramount. You have to be cautious with overly aggressive rates in patients with heart failure, maybe pulmonary hypertension or underlying CKD. Pouring in fluid could easily tip them into volume overload, pulmonary edema.
Making things work.
Right. So in those patients, you start slower, maybe 1.5 mmHg, monitor urine output even more closely, maybe use other measures if available, like CBP trends or even dynamic measures if they're in the ICU. You tailor it to the patient.
Always tailored to the patient. Okay, hemodynamic stabilizing. Next big question. Nutrition. The old dogma was NPO, rest the pancreas. That's completely changed, hasn't it?
Completely flipped. The evidence now overwhelmingly supports early enteral nutrition. That whole pancreatic rest idea, keeping the gut empty, we now know that probably causes more harm than good.
Why is that?
Oh.
What's the mechanism behind early feeding being protective?
It's really about the gut barrier. Keeping the gut fed maintains the integrity of that mucosal lining. An empty gut leads to mucosal atrophy, which makes it easier for bacteria to translocate.
Bacteria crossing from the gut lumen into the bloodstream or into those necrotic areas.
Exactly. And bacterial translocation is a major driver of getting infected pancreatic necrosis, sepsis, worsening SIRS. So by feeding the gut early, you maintain the barrier, reduce translocation, reduce infectious complications, lessen the inflammatory burden. It leads to better outcomes, less organ failure, lower mortality.
Makes sense. So what's the preferred route?
Simplest first. If the patient can tolerate it, even with some mild pain or ongoing enzyme elevation, oral feeding is preferred. Let them eat low-fat solids if they feel up to it.
And if they can't manage oral?
Then the next step is still enteral via a feeding tube. Nasogastric NG is usually fine. Some used to argue for nasojejunal NJ to bypass the stomach and duodenum, but most evidence suggests NG is just as effective and easier to place.
And parenteral nutrition, PN.
Avoid it if possible. PN should really be reserved for cases where the enteral route just isn't feasible for a prolonged period. PN is associated with more infectious complications, especially line infections, and doesn't provide that gut barrier protection.
Good summary. Last piece of supportive care. Pain control. Can't forget that.
Absolutely essential. These patients are often in agony. Adequate pain control reduces suffering, obviously, but also lessens the physiological stress response, which can feed into that whole inflammatory cycle.
IV opioids are the usual go-to.
Yes, IV opioids, often PCA or continuous infusion initially. Those old concerns about opioids causing sphincter of otispasm and worsening pancreatitis, they've largely been dismissed by current evidence.
But still need to be careful about side effects.
Of course, monitor for sedation, respiratory depression, especially in patients who might already be borderline from a respiratory standpoint. Find that balance.
Okay, so supportive care is optimized. Fluids, nutrition, pain control. Now we need to think about the underlying cause, the etiology, because management differs. Gallstones are the most common cause, right?
By far. And for gallstone pancreatitis, the key decision is about timing the cholecystectomy. It depends entirely on severity.
So for mild gallstone AP?
For mild cases, the gallbladder should come out during the same hospital admission, before they go home.
Why the urgency?
Reduces the risk of a recurrent attack, which can happen quickly and is often worse than the first episode. Get it out while they're already in the hospital.
Okay, but what if it's severe or necrotizing pancreatitis caused by gallstones? Delay the surgery then?
Yes, absolutely delay. Operating during the peak of severe inflammation is risky. Much higher morbidity, mortality. So for severe or necrotizing cases, you wait. Let the inflammation cool down completely. Usually that means delaying cholecystectomy for several weeks, maybe 2 to 8 weeks after the acute phase resolves.
Makes sense. What about ERCP? When do we need an urgent scope for gallstone pancreatitis? It gets misused sometimes.
It does. Routine early ERCP for all gallstone pancreatitis is definitely not recommended. It has risks itself.
So when is it indicated urgently, say within 24 hours?
Strictly reserved for 2 situations. One, if the patient has concomitant cholangitis, fever, jaundice, high white count, maybe RUQ pain suggesting infected bile. Or 2, if there's clear evidence of ongoing common bile duct obstruction, like a rising bilirubin or imaging showing a persistent stone.
If neither of those is present,
then no urgent ERCP. Manage medically, let things cool down, and plan for the cholecystectomy at the appropriate time.
Got it. Okay, next common cause. Alcohol. What's the key intervention there?
With alcohol-induced pancreatitis, the intervention needs to start right there in the hospital. It's about addressing the underlying alcohol use disorder. Brief intervention, counseling.
Does it actually help?
Studies show it does. Patients who get some form of intervention during that index admission are more likely to engage in treatment and have lower rates of recurrence, and importantly, progression to chronic pancreatitis down the line. It's a crucial opportunity.
Right. And then there's hypertriglyceridemia-induced AP. Often presents very severely, right, when TGs are over 1,000.
Yeah, these can be nasty. The goal is to get those triglyceride levels down fast. Management often involves an IV insulin drip.
Even if they're not diabetic?
Even if they're not diabetic, insulin helps activate lipoprotein lipase to clear the triglycerides. In really severe or refractory cases, you might even need plasmapheresis.
And then long-term?
Long-term, it's strict diet and usually lifelong lipid-lowering therapy, typically with fibrates, to prevent it from happening again.
Before we move off of etiology, we talk about gallstones, alcohol, triglycerides, but we should probably mention genetics briefly, right? Especially for recurrent or idiopathic cases.
Good point. Some people are just predisposed. Mutations in genes like PRSS1, the cationic trypsinogen gene, or SBI-NK1, which is an inhibitor, these can make individuals much more susceptible to getting pancreatitis, having recurrent episodes, or progressing to chronic disease.
So, worth considering genetic testing in some cases.
Especially in younger patients with recurrent attacks and no clear cause. It helps with counseling about avoiding triggers and understanding their long-term risk.
Okay, now a really important topic, antibiotics. Stewardship here has changed dramatically. What's the absolute rule regarding prophylactic antibiotics in AP?
The rule is firm. Do not use them. Routine prophylactic antibiotics are not indicated, period.
Even in severe cases?
Yeah.
Even if there's necrosis on the CT?
Even then, large trials, meta-analyses, they've consistently shown no benefit. Prophylactic antibiotics don't prevent infected necrosis. They don't reduce other complications. They don't improve mortality. All they do is breed resistance and potentially increase fungal infections.
So when do we use antibiotics? What's the trigger?
Only for confirmed or strongly suspected infections.
Such as?
Well, obviously, if you get a culture back positive from, say, a needle aspiration of a necrotic collection, that's confirmed infected necrosis. Or if they have a clear concurrent infection like cholangitis, a line infection, pneumonia, UTI.
But what if you don't have proof yet, but the patient's going downhill? What raises strong suspicion for infected necrosis?
You're looking for clinical deterioration despite good supportive care. Maybe they were getting better and now have recurrent fevers, or persistent high fever, worsening leukocytosis, increasing left shift, signs of sepsis or worsening organ dysfunction that isn't explained by volume status alone.
Does imaging help?
It can. Seeing gas bubbles within a pancreatic or peripancreatic collection on CT is highly suggestive of infection by gas-forming organisms. But you don't need to see gas to treat if the clinical picture is convincing for sepsis originating from the pancreas.
Okay, so we suspect infection, we decide to treat. What kind of antibiotics do we need?
You need broad-spectrum IV agents that have good penetration into pancreatic tissue, especially necrotic tissue, which can be poorly perfused.
So standard choices.
Often carbapenems, like imipenem-cilastatin or meropenem. Certain quinolones also have decent penetration, sometimes higher-generation cephalosporins combined with metronidazole. The key is getting adequate drug levels to the site of infection.
And ensuring appropriate dosing.
Absolutely. Loading doses, appropriate maintenance based on renal function. Crucial for success.
What about antifungals? Do we add those empirically?
Generally, no. Routine empiric antifungal coverage isn't supported by evidence. Just like prophylactic antibiotics, it increases risks and costs without proven benefit for most AP patients. Reserve antifungals for documented fungal infections or maybe in very complex, prolonged cases with multiple interventions where suspicion is extremely high.
Good stewardship points.
Yeah.
Okay, let's talk about escalating care. When does someone absolutely need the ICU?
Back to the Atlanta classification. Severe acute pancreatitis, defined by that persistent organ failure lasting more than 48 hours, that's your trigger for ICU-level care.
And what does ICU care entail beyond just closer monitoring?
It's about advanced organ support, invasive hemodynamic monitoring, maybe arterial lines, central lines, mechanical ventilation if they have respiratory failure, renal replacement therapy like dialysis if they develop severe AKI, vasopressors for shock, and, of course, continuing that meticulous goal-directed fluid resuscitation.
And for these really complex cases, especially necrotizing pancreatitis, referral to a specialist center is often a good idea.
Strongly advised. Patients with severe or necrotizing AP generally have better outcomes when managed at high-volume centers with dedicated expertise. You need that integrated team, critical care, interventional radiology, GI, expert pancreatic surgeons, all working together.
Let's talk about managing the local complications themselves, the fluid collections, the necrosis. Can you clarify the main types again?
Sure. Broadly, in the first 4 weeks, you can get acute peripancreatic fluid collections, APFCs, which are just fluid, or acute necrotic collections, ANCs, which contain both fluid and necrotic debris. After about 4 weeks, these can mature and encapsulate. An APFC might become a pseudocyst, fluid only, walled off, and an ANC can become walled-off necrosis, or 1, containing solid debris walled off.
And the key distinction for management is sterile versus infected.
Exactly. Most sterile collections, even large pseudocysts or sterile 1, can be managed conservatively. Just watch and wait. Many will resolve on their own.
So intervention is reserved for?
Primarily for infected necrosis or collections. Or if a sterile collection is causing significant persistent symptoms like intractable pain, gastric outlet obstruction because it's compressing the stomach, or biliary obstruction.
And when we do intervene, the approach has really shifted towards minimally invasive options first, right? The step-up approach.
Yes, the step-up approach is now the standard of care, replacing the old way of going straight to open surgery.
So define step-up. What's the first step?
Least invasive first. Usually that means drainage. Either percutaneous drainage, where IR places a brine through the skin into the collection, or endoscopic drainage, where GI goes through the stomach or duodenum wall with an endoscope to place stents into the collection.
Drain the liquid part first.
Right. Drain the pus or infected fluid, give antibiotics time to work, support the patient, and see if they improve. Only if they fail to improve with drainage and antibiotics do you step up to the next level, which is usually some form of necrosectomy, actually removing the dead tissue.
And even for necrosectomy, minimally invasive is preferred.
Definitely preferred over open surgery if feasible. Techniques like VRD, video-assisted retroperitoneal debridement, or endoscopic necrosectomy through the stents. These approaches cause less physiological stress, have lower complication rates, and generally lead to better outcomes than a big open operation.
Now, crucial point, timing. We talked about delaying cholecystectomy in severe cases. We also delay intervention for necrosis itself, right? Why wait? Typically about 4 weeks.
Delaying intervention for necrosis is maybe the most critical principle here. Going in too early, when the inflammation is raging and the collections aren't organized, is dangerous. High risk of bleeding, creating fistulas, worsening systemic illness.
So waiting allows things to cool down and mature.
Exactly. Waiting allows the necrotic tissue to liquefy somewhat, and importantly, allows the body to form a nice, thick, fibrous wall around the collection, creating that walled-off necrosis, the one. Once it's walled off, usually after 4 months, it's much safer and technically easier to drain or debride using those minimally invasive step-up techniques. Outcomes are significantly better with delayed intervention.
Patience pays off. Okay, fast forward. The patient has weathered the storm, managed through the acute phase, maybe had interventions. Now we're thinking about discharge. What are the criteria?
It needs to be clinically driven. They should be hemodynamically stable, off IV fluids mostly. Pain needs to be well controlled with oral pain meds. They have to be tolerating an oral diet. And critically, no signs of ongoing infection or other active complications. Their overall clinical picture needs to be clearly improving.
Makes sense. And then long-term focus shifts heavily to secondary prevention, preventing another attack.
Absolutely. This hinges on definitively addressing whatever caused it in the first place.
So for gallstones, if they didn't get the cholecystectomy inpatient,
if it was mild, it really should have happened inpatient. If it was severe and delayed or somehow missed, they need that gallbladder out, ideally within 2 to 4 weeks after discharge. Don't wait too long, or they risk another attack.
and for the metabolic causes.
Sustained effort needed. For alcohol, ongoing support for cessation is vital. Connect them with resources. For hypertriglyceridemia, it's lifelong management, strict diet, lipid-lowering meds, close follow-up with primary care or endocrinology.
We also need to think about the long-term damage the pancreas might have suffered, especially after severe or necrotizing episodes. What are the main sequelae to monitor for?
2 big ones: pancreatic exocrine insufficiency, or PEI, and diabetes.
Let's say PEI first. How common is that?
More common than you might think. Up to maybe 35% of patients after AP, particularly after necrotizing disease or if alcohol was the cause. The pancreas just can't make enough digestive enzymes anymore.
And that causes?
Maldigestion. Patients get steatorrhea, fatty stools, weight loss, vitamin deficiencies. We usually screen for it with a fecal elastase 1 test. If they have PEI, they need pancreatic enzyme replacement therapy, PEAT, with meals. Dosing can be tricky and needs adjusting.
Okay. And the other big one, diabetes.
Yes, specifically pancreatogenic diabetes, sometimes called type 3C diabetes. This happens when the inflammation destroys enough of the insulin-producing islet cells in the pancreas.
How is it different from type 1 or type 2?
It often involves deficiency of both insulin and glucagon because the whole islet is damaged. This can make blood sugar control really brittle, with risks of both highs and lows. Needs careful screening, especially after severe AP with significant necrosis, and often requires specialist management.
So lots to think about long term. Finally, looking ahead, what's the biggest gap in our current management and where is research heading?
The biggest unmet need is still that we lack a specific drug, a disease-modifying therapy. We're great at supportive care, we're getting better at interventions, but we still don't have anything that can reliably stop that initial inflammatory cascade once it gets going. Lots of trials for anti-inflammatory agents or immunomodulators have unfortunately failed.
So research is focusing more on refining what we do.
A lot of it is. Refining goal-directed fluid therapy, maybe using more advanced monitoring, like post-pressure variation, using biomarkers better like procalcitonin to help distinguish sterile from infected necrosis or guide antibiotic duration, and optimizing those minimally invasive techniques.
And personalization.
That's the
Yeah.
long-term goal, right? Personalized medicine. The NADDK and others are pushing for research that uses genetics, clinical factors, maybe specific biomarker profiles to predict early on who's going to develop severe disease. So maybe we could target specific therapies to those high-risk individuals in the future rather than a one-size-fits-all approach.
Okay, so pulling it all together from this deep dive, if we had to summarize the core pillars of evidence-based hospital management for acute pancreatitis today, what would they be?
I'd say three main things. First, early and accurate severity stratification using revised Atlanta remembering persistent organ failure is the key marker for severe.
Second, aggressive but smart goal-directed fluid resuscitation, with lactated ringers being the preferred fluid, likely for its anti-inflammatory benefits as well as electrolyte balance.
Okay. And third,
Third, targeted management based on etiology, getting the timing right for cholecystectomy, addressing alcohol or lipids, combined with really strict antibiotic stewardship, only using them for documented or highly suspected infection, and choosing agents with good penetration, and remembering the step-up approach for complications.
it really highlights how managing severe AP effectively requires such a coordinated multidisciplinary effort, doesn't it?
Absolutely. It's the quintessential team sport in hospital medicine. You need critical care, GI, IR, surgery, nursing, nutrition, everyone on the same page, following evidence-based protocols but also applying sharp clinical judgment. The guidelines give us the roadmap, but we still need to navigate based on the individual patient.
Which brings us maybe to a final thought for our listeners to consider in their own practice. We focus a lot on the interventions for complications, like necrosectomy. But think about this. In severe AP, what usually determines mortality isn't necessarily the amount of necrosis itself.
It's the organ failure.
It's the duration of persistent organ failure. So while getting the drainage and surgical timing right later on is important, maybe the biggest impact we can have, the key to really moving the needle on outcomes, lies in perfecting that initial phase. Institutional readiness to rapidly identify impending organ failure, flawlessly execute every element of goal-directed supportive care, sustain those organs, all within those critical first 48 hours. Maybe the real battle for survival in severe acute pancreatitis is won or lost right there, in the initial resuscitation.